Welcome again to yet another NEET paper discussion. So let's begin with the question discussion. First question. An infant is admitted to the ICU with complaints of recurrent jerky movements of all limbs. EEG showed hips arrhythmia. Which will be the anti-epileptic drug of choice? Now this is a question which has two parts. First, you must diagnose the condition, and after that identify what will be the drug of choice in that condition. So we have a child who is having recurrent jerky movements of the limbs. So that essentially means the child is having seizures, and the EEG is showing a classical pattern called hips arrhythmia. So in which condition will you see hips arrhythmia? Hips arrhythmia is a classical seizure pattern seen in a condition called West's syndrome. West syndrome is where you see hips arrhythmia. Now that is almost like pathognomonic. If you see hips arrhythmia, diagnosis is West syndrome. So what is the drug of choice of West syndrome? Now West syndrome has got not like the routine seizure disorders. The drug of choice in West syndrome is ACTH. So hence, since the EEG shows hips arrhythmia, since the child has seizures and the diagnosis is West syndrome, the drug of choice here will be ACTH. There we will not be using the other drugs of choice in this. So West syndrome is also what you call as infantile spasms or Salam seizures. These are all the other names for West syndrome. Classical diagnosis is correctly made by hips arrhythmia. Treatment is with adrenocorticotropic hormones. So very good outcomes if you are treated early. So hence the correct answer is A, ACTH. Let's go to the next question. A mother reported that her baby did not pass urine postnatal day 1. What will be the next step? So day 1, no urine output. So what are you going to do next? Now remember, this day 1 urine, day 1 meconium. Out of these two, which is more important? What is more important is the day 1 meconium. Because in the antenatal period, the child has been constantly passing urine, which is why liquor is formed. So the patency of the urinary tract in a child who is born with adequate liquor has already been established. If liquor is adequate, amniotic fluid is adequate, what does that mean? That means that the child has already passed enough urine, the kidney is functioning, and the urinary tract, the ureters, the bladder, the urethra, all are completely patent. That is why liquor was adequate. And that means there has been no major obstruction or no major problem in the kidney urinary tract before birth. Immediately after birth, what happens? Immediately after birth, we have this child who has come out, and that time, immediately when the child is born, the feed is yet to be established. Feeding does take a day or so. The child tends to have a great amount of sleep in the first 24 hours of life, does not easily get up to feed. And the child already has a lot of water in the skin because the child has been completely enveloped in liquor. There's a lot of water in the skin of the baby. So all this water gets reabsorbed in the first 24 hours of life. So infants do not need to pass urine. It's not an emergency for us to immediately make sure that the baby has passed urine in the first 24 hours of life. So that is why even if a child is not passed urine in the first 24 hours of life, baby is active and feeding well, usually we don't need to do anything. However, if a baby has not passed meconium in the first 24 hours of life, then we are really worried. Because intrauterine, there is no way to check if the gastrointestinal tract is patent. Meconium is never passed intrauterine unless the baby has suffered some distress or some infection. Only then will the meconium come out into the amniotic fluid, following which it can get aspirated and have variety of complications. So when the baby is born, that is when the intestinal peristalsis tends to begin. So in the first 24 hours of life, we have to watch very carefully and see that the meconium is passed. If meconium is passed, that is the first evidence we have that the gastrointestinal tract is completely patent and there is no obstruction. If meconium is not passed in the first 24 hours of life, we have to watch and see if there's an obstruction in the passage of the gastrointestinal tract, either some atresia, anorectal malformations, etc., or there is a meconium plug wherein the meconium is very thick and cannot be passed, or meconium ileus. So whatever causes it may be, meconium not being passed in the first 24 hours of life is usually pathological. However, we don't have any such fears with respect to urine. So urine, you can wait for up to 48 hours of life for the child to pass urine, because child had just passed urine all along in the 7 months of, by the time the urine gets formed and LICA gets formed, child's patent urinary tract has made sure that amniotic fluid is plenty. So day 1 child did not pass urine, there is no need to panic. What you have to do is reassure the mother, give good breastfeeding and observe the child so that within 48 hours of life the child should pass urine. So the correct answer will be C. You do not need to do IV hydration. You don't have to shift to the NICU and investigate feeling scared that there's some renal issue. And definitely you don't have to start formula milk. It is not right, because the first 24 hours of life babies do feed a little less. But there is enough of subcutaneous fluid, there is reduced requirement in the baby in the initial first 24 hours. So what is there in the body plus the little colostrum that is given by the mother is sufficient to maintain the blood sugars and the water requirement of the baby for the first 24 hours. So do not panic if the child does not pass urine in 24 hours. What you need to do is just continue breastfeeding and observe. However, as I discussed with meconium, it is not the same way. Similarly, if I tell you that this baby did not pass urine for the first 24 hours and there is also oligohydramnios or amhydramnios, because of which this was born through emergency cesarean section. Yes, in those conditions, baby not passing urine in the first 24 hours is very, very significant. That time I would advise to shift to NICU and investigate. Baby who was born with good amount of LICA, there's nothing to worry. The correct answer will be C. Continue breastfeeding and observe. Next question. Regarding the high-risk infant, which of the following is correct? Is a high-risk infant the one who has a weight of 2.5 kg? No. Babies below 2.5 kg are in fact high risk, and even that has become a question with the new clinical nutrition scorings. Birth order more than 3, not essential. In our country, we have many families where birth order is more than 3. So no, that's also not a high-risk situation. Single parent, yes. Single parent having a baby with no help from the other parent, this is a little difficult condition, especially as the child grows and starts to ask questions. There's a lot of burden on the single parent to bring up the child single-handedly, as well as a lot of pressure on the child to explain where the other parent is to his or her friends. So these are all have child psychological and parent psychological challenges. As the child grows up, these challenges do exist. So yes, having a single parent can make that child a high-risk infant. Artificial feeding. Yes, artificial feeding is something which we never advise. Always breastfeeding is protective, breastfeeding is sufficient, and breastfeeding is the best food for the baby. So a child who is artificially fed is at a risk for diseases, obesity, cardiovascular diseases, diabetes. If you look at the list is endless. Primarily in today's condition, focusing on allergies and asthmas. So artificial feeding does predispose the child to high risk? True. Birth weight less than 85th centile, that is not a high risk. Birth weight at 50th centile is what is 2.5 kg. So artificial feeding and single parenting are by far among this list the most correct options, which will go towards the high risk infant conditions. So where is the correct answer there? You have 3 and 4 is A. So the correct answer is A. 3 and 4 single parenting and artificial feeding being the components of high risk among this list. Next question. Multiple fractures have been detected in the antenatal ultrasound scan. Remember, in the intrauterine, where the baby is nicely cushioned with LICA, there only if you are having fractures, automatically it means that there is some problem in the bone of the child. Which are the options? You have achondroplasia. Is that a problem of the bone? No, that's a problem of the cartilage. Not the right answer. Cretinism, problem with thyroid. It has problem with muscles, not with bones. Marfan syndrome is a condition where the child has got tall stature, however the bone density is not affected. There are long bones, however density is not affected. So there are no frequent fractures per se. Osteogenesis imperfecta. This is a condition where the bone formation itself is genetically altered and you have weak and fragile bones being formed. So yes, in that condition of osteogenesis imperfecta, you can have multiple fractures even from simple movements inside the uterus. So the correct answer here is B. If you have multiple fractures in the antenatal ultrasound scan, the correct answer will be osteogenesis imperfecta. Which of the following diseases has an autosomal recessive inheritance? A. Osteogenesis imperfecta, B. Treacher-Collins syndrome, C. Achondroplasia, and D. Cystic fibrosis. Let's look at it one by one. So, osteogenesis imperfecta is essentially example for autosomal dominant condition. Treacher-Collins syndrome is one of the syndromic examples we give for autosomal dominant inheritance. Achondroplasia is also one of the classical examples for autosomal dominant inheritance. However, we have cystic fibrosis. This is an example of autosomal recessive inheritance. So, among this list, the correct answer is D. Cystic fibrosis is the example for autosomal recessive inheritance. Next question. A child with exercise fatigue comes to the OPD. The features were suggestive of McArdle's disease. Which of the following enzymes will be deficient in this? Now, McArdle disease is a storage disorder. And it's a storage disorder because there's an enzyme deficient because of which the abnormal metabolite gets stored in the skeletal muscles. Storage disorder primarily involving the skeletal muscles. So when you look at McArdle's disease, skeletal muscle disorder, so primarily you should just have to connect the skeletal muscle disorder to these enzymes. So you know McArdle's disease, skeletal muscle, the muscle is also called myo. So the correct answer will be myophosphorylase because myophosphorylase is the primary enzyme in the muscle which can produce this condition. And McArdle's disease, there is deficiency in this enzyme. So deficiency of myophosphorylase produces McArdle's disease, which is a storage disorder. Let's look at the other options. Glucose 6-phosphatase. This glucose 6-phosphatase is seen where? Glucose 6-phosphatase deficiency. It is G6PD, classically for hemolytic anemia. So it has nothing to do with exercise fatigue and features of McArdle's disease. Lysosomal glucosidase. This is for lysosomal storage disorders. Phosphofructokinase, another storage disorder. But all these lysosomal glucosidase, phosphofructokinase, these all affect the liver and the CNS. Child will not just have exercise fatigue. So that is why in McArdle's disease, the enzyme which is deficient is myophosphorylase. That is why the child is having exercise fatigue and otherwise he is okay. So the correct answer is A, myophosphorylase. Next question. A child presented with hepatosplenomegaly, mental retardation and bone pains. So remember there are 2-3 system involvement here. You have hepatosplenomegaly, which is involvement of the reticuloendothelial system. You have mental retardation, involvement of the CNS, as well as bone pains, which is the locomotor system which is involved. The bone marrow biopsy shows crumbled paper appearance. Now, when you have this kind of hepatosplenomegaly, mental retardation, as well as bone pains, which means there is some metabolite which is getting stored in all these places, which is hampering the functioning of these organs. This abnormal metabolite is stored in the liver and spleen, so hepatosplenomegaly. You have the abnormal metabolite stored in the brain, so mental retardation. You have the abnormal metabolite accumulating in the bone marrow and pressing on the marrow. That's why there is the bone pains. The bone marrow biopsy showed a crumpled paper appearance. This suggests this is a storage disorder. Your diagnosis is which storage disorder has this condition. So you have CNS as well as reticuloendothelial system. So the classical storage disorder where you have this crumpled paper appearance is the deficiency of glucose cerebrosidase. This is the storage disorder where you will have this hepatosplenomegaly, mental retardation, bone pains, and the bone marrow showing a classical crumpled paper appearance. Again, here in none of these three conditions, you're going to have a stored, one is a hemolytic anemia, the others are all enzymes that are responsible for digestion of like glucose and galactose. So because of this, none of them will present with a storage disorder where you have this kind of crumpled paper appearance in the bone marrow. That is why the correct answer is A, glucose cerebrosidase. An 8-year-old male child presented the OPD with purpura over the lower limbs and buttocks. He also reported having arthralgia and abdominal pain. There was a previous history of upper respiratory tract infection in this child. What is the treatment option? So this is again a problem solving 2-stage MCQ. First is, let's come to the diagnosis. You have purpura, classically over the lower limbs and buttocks with abdominal pain and arthralgia. So this kind of distribution where you will have the purpura over the buttocks, mostly over the posterior surfaces of the lower limbs, including the anterior surface in the shins, etc. This is classical with abdominal pain and arthralgia of Henoch-Schönlein purpura, HSP or Henoch-Schönlein purpura. So in this condition, you will have previous history of upper respiratory infection also. How will you treat Henoch-Schönlein purpura? Henoch-Schönlein purpura is a vasculitis. It's a vasculitis condition and it's an inflammatory condition. So vasculitis or inflammatory condition. Since this is secondary to having had an upper respiratory infection, afterwards the body tends to develop this inflammation. There is no treatment of this inflammation with drugs like antibiotics, etc. So what you have to give are anti-inflammatory drugs. So anti-inflammatory drugs which work post-infection are classically steroids. This is the first line of drugs. Among the list of other immunomodulators and stronger anti-inflammatory drugs, glucocorticoids are the safest among this group. So they are the first line of management of Henoch-Schönlein purpura. So the correct answer is C, glucocorticoid. Now look at the other options. You have cyclosporin, azathioprine and methotrexate. These are all very, very strong, potent immunomodulating drugs. Hence, they are not used in a simple, quite benign condition like Henoch-Schönlein purpura. Hence, the correct answer is C. Glucocorticoids are the drug of choice which are first used. Remember, not all Henoch-Schönlein purpura require steroids. The extensively severe one, where they have severe abdominal pain, arthralgia, difficulty in walking, extensive rash, these are the places where you need to use a glucocorticoid if ever. Next question. A 4-month-old child of an HIV positive mother presents with recurrent diarrhea. What will be your next investigation? Remember, this is a HIV positive mother and this child has come with recurrent diarrhea. What is the next test that you're going to do? Ideally, this has 2 limbs. One, you're going to evaluate for the recurrent diarrhea and see why the child has recurrent diarrhea. Because most of the HIV positive mothers go for replacement feeding. We do advise exclusive breastfeeding, but many mothers do opt for replacement feeding because there's no mixed feeding option. So most mothers opt for replacement feeding. Those children who are replacement fed do have recurrent diarrhea because it's a cow's milk formula, there's cow's milk allergy, there is unsterile way of preparing the milk, over diluted milk, unsterile way of washing and cleaning the bottles. So recurrent diarrhea can occur even in a non-HIV positive mother's baby, especially when they are replacement fed. So what will be your next investigation in this child? Well, let's look at the options. A, check for giardiasis. Giardiasis doesn't cause recurrent diarrhea in a 4-month-old. Giardiasis occurring in a 4-month-old, even in HIV positive state, is very, very rare. So we're not going to check for giardiasis. Check for HIV P24 antigen? No. There is no way to check for HIV P24 antigen in a 4-month-old baby. Stop breastfeeding and start highly active antiretroviral therapy immediately. No, there is no way to prove HIV positive child with immunosuppression causing recurrent diarrhea in this child at 4 months. So we are not going to stop breastfeeding and we are not going to start HAART immediately for this baby. Children of HIV positive mothers who are breastfed can also have recurrent diarrhea. So what we like to more evaluate is see whether this child is HIV positive or not. Because if the child is HIV negative, then the correct diagnosis of HIV is only made at 18 months of age. But at least we'll have an idea. If the child is HIV positive and if the viral load is high, we can have an idea as early as 4 to 6 months of age. So what we are going to do is that we are going to see whether the child is HIV positive, and so this is an opportunistic diarrhea, or this is just that the child is having recurrent diarrhea either because of unsterile replacement feeding, or the child is having recurrent diarrhea because of any other infection which can occur in small babies even though child is breastfed. So that is why the diagnosis what we want to find out is whether what is the child's HIV status. So for that what you'll do a dried blood spot for HIV RNA PCR. That's the next best test that you can do. Ideally this would be done at 6 months of age. Then at 1 year and at 1.5 years of age, we'll be doing the antibody analysis. However, since the child is symptomatic, we'll be again redoing it at 4 months of age. So the answer will be D. The next investigation what we want to do is just to see whether this child is HIV positive or not. So HIV RNA PCR with dried blood spot. A 6-year-old male with history of recurrent blood transfusion has come with pains in the hands and feet. The hemoglobin electrophoresis shows increased HbF, HbA2 and a peak is seen in the S window. What is the diagnosis? Now there are lots of clinical clues here. Child has come with recurrent blood transfusion. So most probably diagnosis here is hemolytic anemia. Hemolytic anemia. Then he presents with pains in the hands and feet. Pain in the hand and feet is classically called because of dactylitis, because of the sickle cell obstructions. So dactylitis. So already before the investigation has come, the presence of pain in the hands, feet, sometimes acute chest pain, acute abdominal pain, all these are classically seen in which of the hemolytic children? It is seen in sickle cell anemia. So already before investigation, we have come to a diagnosis. Diagnosis is sickle cell anemia. Now what does the investigation show? It shows there is a peak in the S window. There is increased HbF, which is suggestive again. This again shows that there is hemolysis. And a peak is in the S window means there is hemoglobin S. Hemoglobin S is diagnostic of sickle cell anemia. So automatically what is the diagnosis? The answer is C, sickle cell anemia. Next question. A neonate was found to have a thyroid stimulating hormone of more than 100 international units per liter on day 4 of life. Ultrasound shows a eutopic thyroid gland which is present in place. What should be the next investigation? So you have this hypothyroid neonate. Hypothyroidism, most probably congenital hypothyroidism. But the thyroid gland is still present in place. So how do you want to diagnose that? The thyroid gland is there. Then why does the child have hypothyroidism? This is what you want to find out. So the next step what you're going to do is to find out the functioning of the gland. The gland is there, no doubt. But is the gland functioning appropriately? That is what you want to find out. So the next test what you want to do is the thyroid nuclear scan. That will tell you the excretion of the nuclear isotope and the functioning of the gland. Urine iodine concentration is not required. There is no need to monitor that. Thyroid receptor antibodies. This is all not done in evaluation of congenital hypothyroidism. This would more be an option in case of acquired hypothyroidism and when you are having poor response to therapy where how much ever thyroxine you give, the child is not responding, older child. There maybe you will do a thyroid receptor or anti-thyroglobulin antibodies all can be done. But in newborns, the next test what we are going to do, first we do a routine screening of thyroid stimulating hormone. TSH is high. Step 2 is to find out whether gland is there or not. So step 2 is to see for the gland, see if the gland is there in the neck. Step 3 is to find out whether the gland is functioning or not. That is done by thyroid nuclear scan. So the correct answer is C. The next step is the thyroid nuclear scan. Next question. A 11-month-old baby was brought with a history of incessant crying. On examination, a tender mass was seen in the right lumbar region. An image of barium enema study was done, which is given. This is the barium enema which is given. What is the diagnosis? So you have excessive cry, which means there is some amount of severe pain in the baby. A tender mass palpable in the right lumbar region. Now there is some mass which is very tender in the right lumbar region, which means there is some swelling and something which is there in the right lumbar area, for which they have done a barium enema. And the barium enema has shown this. Now this is the enema. The enema has gone through the sigmoid colon, gone through the descending colon. It has gone through partly of the transverse colon. Now at the transverse colon, this kind of appearance is seen. This is called the claw sign for barium enema. Classically, this claw sign means there is some obstruction at this level, which means at somewhere near the hepatic flexure, there is an obstruction, hepatic flexure of the colon. That obstruction has got swollen, which is what is palpable as a tender mass in the right lumbar region. So where do you see the claw sign? Incessant crying baby, you will see it in intussusception, which is the correct answer. So in intussusception, you will see the claw sign. And what also you will also see is an empty right iliac fossa. So this empty right iliac fossa with a palpable mass in the right lumbar fossa is called sign D dance, or the dancer's sign. This is what this whole sign is about. Classically seen in intussusception. Do you see this in duodenal atresia? No. There is no question of doing barium enema itself for duodenal atresia. Duodenal atresia would have presented at birth. In volvulus, you will not see this classical claw sign in barium enema. In volvulus, there you will find a complete obstruction. There will be no entry of the dye from the point of the volvulus. In pyloric stenosis also, here like continuous vomiting presenting in the first 3 weeks of life. So that's also not the right answer. Next question. A 12-year-old male presents with bloating, recurrent loose stools and features of malabsorption. So bloating, recurrent loose stools and features of malabsorption. His HLA-DQ2 is positive. What should be the next best step in management? Again, a 2-step problem solving MCQ. First, what is the diagnosis? We have loose stools, bloating, malabsorption. So this is a malabsorptive disorder. If you look further, these children will also be severely malnourished and have all features of fat soluble vitamin deficiencies. Okay, so you have malabsorptive disorder, which is a common malabsorptive disorder. You have celiac disease. You have lots of other malabsorptive disorders, but commonest what we see, especially up north, is the celiac disease. In celiac disease, do we have HLA-DQ2 positive? Yes, HLA-DQ2 is positive in celiac disease. Here's where you have the transglutaminase antibodies. So transglutaminase antibodies will be seen when you have HLA-DQ2, which is what's the diagnosis of celiac disease. So what is the management of celiac disease? Management of celiac disease is the gluten-free diet. So the correct answer is C, gluten-free diet. Low lactose, high lactose, none of these will be the diagnosis for a child with malabsorption. Remember, lactose produces intolerance. Child drinks milk, child has bloating, loose stools. However, there will be no features of, these features of malabsorption will not exist. In this process, what will the child do? Child himself will start avoiding lactose containing foods, following which child will be fine. There will be no problems occurring only if the child takes lactose. That is why this lactose intolerance is not the answer. Hence, A and B are not the correct options. A child presented to OPD with multiple episodes of loose stools and repeated vomiting. He was lethargic and not able to drink breast milk. Skin pinch was going back very slowly. Which grade of dehydration does the child have? Now, how would you look at grade of dehydration? You look at grade of dehydration based on certain points. A, the first one, sensorium. 2, tears, 3 appetite, oral cavity, skin pinch, urine output. Now these are the ways you're going to identify signs of dehydration. A child who is well hydrated will have normal everything, normal sensorium, tears present, fair appetite, oral cavity is moist, skin pinch goes back very fast. When we say very fast, is less than 2 seconds. Urine output is normal. A child who is moderately dehydrated, that is a child with no dehydration. A child who is moderately dehydrated will be irritable sensorium, tears, eyes will be dry, appetite, child will be thirst. Thirst will be very high, child will be very thirsty and eager to drink. Oral cavity will be dry. Skin pinch will go back normally, urine output will be normal. This is a moderately dehydrated child. Now coming to severe dehydration, sensorium, child is dull, lethargic, maybe even be unresponsive. Tears are dry. Thirst, child does not feel like eating or drinking. Child does not show any interest in thirst. Oral cavity dry. Skin pinch goes back very slowly. Urine output is reduced. These are signs of severe dehydration. So here what do we have? We have lethargy, we have poor thirst, and we have skin pinch going back very slowly. So that is why the correct answer is C. This child is in severe dehydration. A 2-year-old premorbidly normal, well-thriving child presented with sudden onset of breathing difficulty while playing. Chest X-ray shows right side hyperinflation with a normal left lung. Which of the following statements are true regarding this child? Has the child developed acute laryngotracheobronchitis? Now, in acute laryngotracheobronchitis, you will have the larynx, the trachea, and the upper bronchi being affected. These children have what is called the croup syndrome, low-grade fever, brassy cough. Along with that, some amount of inspiratory stridor can be present. There will be no history of sudden breathing difficulties in these children. X-rays are usually normal. The X-ray of the neck will show you something called the steeple sign of croup. Steeple sign. This is what will be seen. So hence this is not the right answer. Child does not have laryngotracheobronchitis. Focal area of decreased air entry will be suggestive of foreign body. Now, the X-ray shows right-sided hyperinflation. So, when you have hyperinflation in one side and the other side being normal, remember in foreign body, auscultation decides which side is the abnormality, not the chest X-ray, because the type of the obstruction can be different. If you have a complete obstruction, that side lung can be collapsed and the other side will be normal, maybe hyperinflated also. If you have one side where the obstruction is partial, you can have that side on X-ray showing hyperinflation because of ball valve mechanism and the other side being normal. So don't look at the X-ray and decide which side is the obstruction all the time. Always go by auscultatory findings. So here they have not given us auscultatory findings. They are asking us, in the X-ray you have right side hyperinflation and left side normal lung. So most probably this is a foreign body which is having a ball valve mechanism in the right main bronchus, and because of which the air is able to go in but not able to come out. So that is the reason why we are assuming that you will have this focal area of decreased air entry in the right side, which will primarily have the signs of foreign body. In complete obstruction, ball valve mechanism leads to such a condition. Remember, in complete obstruction, you will always have collapse. You will never have hyperinflation. In partial obstruction is where you have the ball valve mechanism, where the air goes in, the bronchi expand when the air go in. So the ball allows the bronchi to expand. That little area is there through which the air goes in. At expiration, the bronchi collapse. So when the bronchi shrink or come down, that time the ball becomes a snug fit. So the air is not able to come out of the lung. So that is only in partial obstruction and not in complete obstruction. Flexible bronchoscopic removal is the management of choice. Now remember, it depends upon the level of the foreign body and which the foreign body is to decide whether it can be removed by flexible bronchoscopy. Sometimes deep foreign bodies which have gone deep into the branches of the primary main bronchus, it's very difficult for the flexible scope to reach that low. And usually to remove foreign bodies through a flexible scope is very difficult because the foreign body will not be allowed to be maneuvered through the scope. So usually for foreign body removal, the management of choice is rigid bronchoscopy. Hence, this is also not the right answer. That's why the correct answer is, if you have a focal area of decreased air entry, which is what you are expecting on the right side, you will have a very good evidence of foreign body in the right side with ball valve mechanism because of partial obstruction. Next question, identify this abnormality in this newborn baby. Now here you have this condition here. Now if you look, this condition is in midline. See, this is in midline. This is just above in the pubic area. Pubic area, midline. It's as though tissues never got covered. The normal rectus abdominis, the fascia, the skin and subcutaneous tissue never got covered in this baby. So in the midline, in the pubic area and the suprapubic area, what is the diagnosis that you're going to have? You're going to have a diagnosis of urinary bladder extrophy, because if you can see, even the genital areas are very malformed. Malformed urogenital areas. So the diagnosis is bladder extrophy. And look at the options. The options they have given A and B are anterior abdominal wall defects. Now remember, in omphalocele, the genitals of the child will be normal. The area of the umbilicus, the intestinal loops will herniate through the umbilicus. So you have the abdominal wall, and through the umbilicus you will have this huge swelling where the loops of the intestine will be seen. That is omphalocele. Gastroschisis is in the abdominal wall. The umbilicus is here, the umbilical cord is here. However, laterally, here you will have the herniation of the loops just lateral to the umbilicus. That is a lateral abdominal wall defect. So that is gastroschisis. Everywhere you should see intestinal loops and the umbilical will be seen, the genitals will be normal. So hence it is not omphalocele and it is not gastroschisis. Patent vitalointestinal duct. In patent vital intestinal duct also, you will find the umbilicus being almost near normal, and you will find a patent duct here through which you can have excoriated secretions, gastric secretions, sometimes little meconium, all of it coming out through a patent vitalointestinal duct. So you will not have this kind of anterior abdominal wall defect. Hence, this is also not the right answer, and the correct answer is C, urinary bladder extrophy. Next question. A child with history of recurrent UTIs comes to the OPD. X-ray findings are like this. What is the most probable diagnosis? So what is this in X-ray of? This is showing a vesico-ureteric reflux, most probably in an MCU. This must be a micturative cystoarthrogram. And what you can see is that this is the dye in the bladder. And when the bladder is micturating and contracting, what is happening to the dye? The dye is going back up into the two ureters, and it has reached as high as up to the renal pelvicalyceal system. So the dye has gone back up the two ureters, right up to the kidney pelvicalyceal system, which means, and look at the ureters, ureters are dilated and tortuous. So you have dilated and tortuous ureters. Hence, what is your diagnosis here? Diagnosis here is vesico-ureteric reflux, and if they ask you what is the grade, when it's such high reflux with dilated tortuous ureters, dilated pelvicalyceal system, then the grade is grade 5 vesico-ureteric reflux. Bladder diverticulum will not have vesico-ureteric reflux. In bladder diverticulum, there is no way that the dye should enter into the ureter. Ectopic kidney, that you should see the ectopic kidney, kidneys are normal in place. Vesicocolic fistulas should show that the dye is entering into the part of the colon and should be seen in the intestine. That is not seen. Hence, the correct answer is A, grade 5 vesicular-ureteric reflux. Next question. A 10-year-old boy with generalized edema and massive proteinuria has come. He is diagnosed as minimal change disease. What are all the features of minimal change disease? Light microscopy shows effacement of foot plates of podocytes. Remember, light microscopy can only show you the glomerulus. It cannot show you foot effacement of podocytes. So that is why foot effacement is correct with minimal change disease, but light microscopy cannot show you this. Good response to steroids? Yes, minimal change disease is characterized by good response to steroids. Is minimal change disease more common in adults? No, it's a complete childhood condition. Non-selective proteinuria? No, selective proteinuria where you have albumin being lost. You don't have loss of globulins as much as you have loss of albumin. So the correct answer is B. This is a case of minimal change disease which has very good response to steroids. So with that, we come to the end of the NEET paper discussions. Catch you again later. Thank you.